Welcome back to another podcast of Heal Without Harm, the podcast for you who is frustrated with the medical system and you're looking to take your health into your own hands. You are in search of more natural answers, and we are here to expose you to the new and better options that are out there. Today, we've got a guest named Kellie Chastain. She is the CEO of Evolve Healthcare. It is a medical practice that was built from patient-focused approaches and a model that is being more widely adopted and maybe a model that you should actually be using. Kellie, welcome.
Thank you.
I'm excited to have you here today. I know we talked a little bit beforehand about kind of the route you took going through the administration side of things in the medical world, and then end up coming around to Evolve Healthcare and helping build that and creating, like I said before, kind of a more patient-centered approach. And so give me some background, or give the listeners a background on where did Kellie start and how did you end up here today, ultimately?
Okay. I started out as a health information technician, associate's degree in that, medical records and coding, for those of you that don't know what the health information technician is. And so that landed me my first job out of college as the director of coding for a big multi-specialty clinic, educating physicians and nurses and things like that as far as how to document what they were doing so that they could get paid appropriately. That was really my primary focus. And then eventually obtained my MBA with the goal of being a CEO at a hospital. Of course, that was over the span of many, many years. And I'm a little bit embarrassed to say how many years I've been in healthcare. But anywho, I took a position as a CFO who had a really close relationship with the CEO position at a behavioral health hospital in Austin, who was corporate owned, and learned real quick and in a hurry that I was not cut out to be a CEO of a hospital. And actually at that time was a little bit uncomfortable, uneasy, didn't like the way traditional healthcare was going. In that hospital, I saw fantastic clinical care, but then was living the business side of that when it came to insurance governance and how much influence insurance had on really the quality of care that we could provide. And so honestly when I came back from Austin, I was looking to get out of healthcare.
And this was about what year?
So that would have been about 6-7 years ago.
Okay. Gotcha.
So I was in the traditional model from 1996 until about 7 years ago, 6-7 years ago.
Gotcha. And we'll pick back up on this. We'll kind of come back to like 6-7 years ago. Where did you go from there? Because I've only been in like being a physical therapist for about the last 5, and even in those 5 years, it's taken a stark downturn, right?
I would agree.
At least in the physical therapy world, they're cutting reimbursement rates by like 8%, which means the insurance is literally paying less for our care, even though the research has never been better on the benefits of PT. And so now we're making less and less money, so we have to change how we treat, and then we get less quality outcomes because we can't treat like we want.
Sure.
And so I'm curious, if we go back with you, especially you being on the administration billing side of things, I know you see it from a different perspective. What all changed in that traditional model from like late 90s to 2015-ish?
I think that the reimbursement levels changed probably the most. It wasn't so much that the governance was changing to where it was getting more and more necessarily. One of my first experiences after I took over that position right out of college was with an insurance company who had denied over $400,000 worth of claims for one of our surgeons. And so we had appealed each individual claim, like was the traditional thing you did.
Yeah.
We had a policy that anything that was denied that was over, $50, we would appeal at least one level. This was obviously on a grand scale, so we had to continue to appeal because the surgeries that were done were appropriate. They were founded in good outcomes and things like that. So we appealed it to the highest level with that particular insurance company, to the point where I was sitting across the boardroom table from, I think it was about 7 representatives from that insurance company, one of which was their medical director. And I watched my physician go through each case study and ultimately still be denied.
So in that case, so patient comes in, and I'll have you walk us through, like, patient comes in, gets service. Like, who gets paid, how, when, what do you have to do? But in that case in particular, so they deny it.
Uh-huh.
Who is now on the hook for paying it?
That would be us as the physician.
Okay, so you just lose money.
You just lose it. You have to write it off. If they come back and say it's a what's called a contractual obligation, meaning that we are contracted with that insurance company and that we say we will accept what they allow, that we cannot bill the patient for any portion of it.
Which is in general supposed to protect the patient in a way, correct?
Yeah.
Unfortunately, then it changes your care and then sometimes ends up not harming, but like not benefiting the patient to the best ability because you have to make sure you get paid as the business, as the surgeon and everything. So let's back this up because I think what I see on the cash-based side of things, since that's how we operate, is most patients and most people don't know how the medical system works money-wise.
Right. Yeah.
And so I'm sure you have a pretty decent understanding. So if a patient comes in for, let's say, you have a background in surgery, at least at one point in time, correct? Okay.
Yeah.
So a patient comes in to get a surgery. Who's paying for that? Or like, do they come in, pay their copay, and then what do you guys have to do kind of behind the desks to ask for money? What does that look like?
Back then, and things have certainly evolved over time, but back then we would, if required, we would do what was called a pre-certification or pre-authorization, which is where we send in really basic information to the insurance company, say this is what we're planning for this patient, this is why it's medically necessary, and they say yes or no.
Okay.
And when they say yes or no, when they say yes, it comes back with a caveat that this is not guarantee for payment.
That's to like cover their ass, like from the get-go?
Basically, yeah. And so you proceed, do the surgery, and in most cases back then, there really wasn't like a predetermined coinsurance copay. I mean, you did the surgery, you filed the claim, and then you billed the rest of it. Whatever the insurance came back and said was the patient's portion based on their deductible or coinsurance, then you billed that portion to the patient. But you could only do that if the insurance company actually came back and allowed the payment.
And timeline-wise, so let's say I got my surgery January 1, regardless of, when deductibles turn around and blah, blah, blah. But I get my surgery January 1. You guys ran the pre-cert. They said, yeah, we'll do it. We think. Yeah, right. No guarantee, but we think we will. I get the surgery January 1. How long until you generally would hear back on if they would actually pay and how much they would pay?
It depended on the insurance company, but at that time for Medicare and Blue Cross, you could be pretty much guaranteed that you would have an answer within 15 days or so of billing.
Okay.
Most other commercial insurances at that time, again, this was a long time ago, at that time could be 30, 45
Okay, so they say they will do it. Let's say 30 days later they will. How long until you see payment?
Actually, when they actually process the payment, then you would receive your payment. So Blue Cross, Medicare, it would usually be within 15 days or so. Other insurance companies, it could be 30, 45 days.
Okay. And then this is the other thing.
You received your payment or your denial.
Yeah. And then if you get a denial, then here we go.
Then, yeah. I mean, like those $300,000-$400,000 worth of claims some of them were probably almost a year old because we had been in the appeals process for so long and we had appealed it to the highest levels. Again, we ended up across the boardroom table from the powers that be, if you will, at that particular insurance company. And with the physician presenting each individual case personally. And then they, went back to wherever they officed at and made the ultimate determination that they weren't going to pay any of them. Which then made him have to think about, okay, what do I change within my practice, even though clinically I believe this is the best treatment for this particular type of condition and this, that, and the other, had to change his practice style.
Yeah. So for you guys listening, if you're wondering why certain costs go up, like Kellie's time is valuable. The surgeon or the doctor's time is valuable. I'm sure there was probably other billing people involved. There was lawyers involved. Right. Plus you have the insurance side of people. So if, 4 employees at the practice that you were at is taking time and then you have all the insurance people taking their time, like that's a lot of incurred costs of time.
Right. Yeah.
That now drive up more and more in the care because you guys have to get paid somehow and then you have to end up changing the care. And so when we wonder why do things cost expensive or cost so much, the money ends up getting spent somehow, some way on these kinds of things. And especially if you come out not getting paid at all because they truly did deny it, now you either have to change the style of care to make sure that you get paid, or you have to raise certain rates to knowing that this is going to happen again.
Right.
Have to cover those. So going back to the patient journey, patient comes in, gets surgery day 1. 2 weeks later, you guys find out like, yep, they'll approve it. Does the patient at this point have any idea what they're going to be paying you?
Back then, no. Now there are much more efficient processes. In my understanding, I've been out of that world for a few years now.
Mm-hmm.
So, and it's constantly changing. But back then, there really wasn't a good process for knowing exactly how much the patient would be responsible for.
How well could you even estimate it?
Really, if it was the major insurances, we could estimate based on prior experience. By the time I left that particular practice, which was really robust, there were processes that were starting to happen within the insurance industry that you could get a pretty good idea.
Okay.
But in the early, in the late 90s, there wasn't that great of a process.
Yeah.
So it was basically we would look at historical and then estimate from there.
So
but it still wasn't general practice to collect at time of service. And so from a PR standpoint, you had to be that was a little tricky too.
Yeah.
Now it's common practice.
Okay. So they get, how long would it be until they get a normal bill in the mail? I know these are all, it depends, but
sure.
If you got notification 2 weeks later, that 15-day turnaround, how long until that patient's getting the bill?
Back then, probably 7, 10, 15 days, potentially 30
After
days at the latest.
Okay.
After the insurance company had processed and paid.
Okay. Because I think that's my biggest frustration whenever I go to a doctor who's, we'll say like a hospital or something big like that. It's like you just have this like nail biting experience afterwards. Like, all right, well, I wonder when we're going to get our bill. And then now, the anesthesiologist bills you, the radiologist bills you, the surgeon bills you, the surgeon's surgery center bills you, and then you go back to the person afterwards for the follow-up, and that's a different bill, and you're like, good Lord, like how many of these bills am I going to get? And they're all just different prices. You don't even know who to call to fight before I go on too long of a soapbox. But that's where it's like, if we can get some clarity on why these things take place, I think that's where a lot of people will just know what to expect going in, or at least have a little bit better lay of the land.
Right.
Okay, so they come in for surgery January 1. A couple weeks later, you guys get notified, denial or approval, paid, and then a week to 2 weeks after that, they'll generally get the bill in the mail.
Correct.
Is about how it works.
For the most part.
Okay, got it. There was one other question I wanted to ask on that, but I cannot remember. And so let's go back to 2015, 2016, or 6 or 7 years ago. To me, those are the same, but that's, I guess, about 9 years ago. So my perception's a little bit off. So you start moving out of Austin and getting out of the CFO position. Where did you go from there?
So there I went to a practice here in Wichita as an administrator again. Like I said, when I first decided to leave Austin and come back, I really had every intention of getting out of healthcare because I was so frustrated with it. Ran into some roadblocks just because all of my experience had been in healthcare finance in some way or another. And so ended up as an administrator at a local practice, and which was just insurance-based, still humming along, doing the same thing.
Family medicine or like
it was family medicine.
Care?
It was primary care, yeah. But we had one physician in particular who had already, and I really, consider him a pioneer, if you will, of this type of model. He was doing it in the hormone space. But he had cut his practice down to where he was doing hormone-based practice, cash-based services, probably at least half the time when I met him. And then primary care the other half of the time. He was moonlighting in the ER. So he had a lot of experience in just traditional medicine and what he called the sick model.
Yeah, for sure.
But had started to expand and get really excited and passionate about the his hormone practice, because he was seeing that that's the way out of the sick model, not from a monetary standpoint, but for patients to get out of the sick model cycle.
Well, we know we know if you're wanting to utilize your insurance benefits, they already direct care based off what they will and won't pay for, right? And so we have to follow the money because the practice doesn't exist if we don't get paid.
Sure. But what made him passionate about it was really, that's how I get, and I remember, seeing him at one of his presentations, educational presentations for patients, because he would do that like monthly. And he had a slide that was all these people walking towards this cliff, and then there was an ambulance at the bottom of the cliff. And he said, "This is my ER, is the ambulance at the bottom. all these people are moving along through our current sick model, and they are going to fall off the cliff, and that's where I meet them in the ER. And he said, this isn't the kind of future that I want for the patients that I encounter.
Mm-hmm.
And so, like I said, he was living that. I mean, that was, a decent portion of his livelihood was working in the ER. But his vision was to do something different because he wanted to catch people upstream before they fell off the cliff.
So a couple of things on there. One of them, if you don't mind, define like traditional or insurance-based model just for the people who don't know these terms. And then what is exactly like cash-based care?
Okay, so the insurance model, you go in, it's a fee for service. So the physician sees you, or a surgeon sees you, whatever that looks like. They provide your service. They submit the claim to the insurance company. They pay what they're going to pay, leave whatever coinsurance deductible that the patient's responsible for. And then the practice or the hospital or whoever then bills the patient for whatever the service is. Again, just like that example in the beginning where, the surgeon does the surgery and then the insurance company decides if they're going to pay for it or not. Doesn't mean that the physician is going to get paid, and so the insurance company is dictating whether or not the service being provided is medically necessary, not the physician and not the patient.
Yeah, which is completely backwards.
Correct. Yeah, and so when we talk about cash-based, that's how the payment system works. But I really feel like it's that we're moving to a model where physicians and patients are partnering to direct their care.
Which I think everybody would agree that's how it should be, right?
Absolutely.
Where I go to the doctor, the one who, I don't know, has a whole background and education and experience of actually treating me, and then they treat me the best way they can, and then we'll worry about payment later. Now, of course, I'll pay up front,
sure,
right? But then I can go file a claim and say like, hey, I saw this provider, here's what we did. Can you please like reimburse me?
Correct.
And then sometimes I do, sometimes I don't. But even if it goes towards deductible, at least I'm getting something out of my insurance for that. I know one question that we'll often get is like, do the people actually have to pay cash for you guys?
No, I mean, card.
Yeah. So essentially,
I would say 90% card. Some people cash. Yeah.
Yeah, for sure. But ultimately, we're just cutting out the middleman, kind of directing the show of insurance. And so I go and pay you for the work that you're doing for me in regards of helping me, and we go from there.
I guess you could say direct payment model.
Yeah, that's a better way to put it. It's one of those things that I know what it means, so I never second guess it. And then I'll people like, do I have to pay in cash? I'm like, no, sorry, no. I acknowledge why you think that, but no, we don't have to.
Yeah, so a direct payment model maybe is better.
And so going back to the doctor that you noticed that was kind of pioneering and doing some new stuff at this at the practice that you were at, how did that go from, hey, I see you, I think what you're doing is cool, and we should do more of that, to actually like having a new practice that runs that way?
Okay, so with that, and it really wasn't even him, I was just super inspired by the way he was viewing healthcare and how he wanted to affect really patients' lives. And we were looking at what I call now aging well. He wanted to help people age well. And meaning that they could get into their 70s or 80s or even 90s and they're still living well. They're not confined by whatever ailment they have. But so I was really inspired by him. But really what changed it for me, I had met a physician who actually was working in in addiction medicine. That was a specialty. And he started talking about direct primary care as a model. And really, it was just casual conversation. We would get together. I didn't work with him, didn't work for him. We would just get together for coffee and just talk about healthcare and how it could be. And he's kind of a visionary too. And in his particular case, he had a lot of addiction patients that didn't have primary care, or they didn't have a physician, but they needed help with their hypertension or whatever. So that's why he was looking at the models. So I went out to research it because I didn't know much about it. Started finding that there are actually studies out there. There are organizations doing studies, granted limited because there's not a lot of funding for it or things like that, but that they were seeing good outcomes. And that's what I've always been interested in is, good outcomes for patients.
It's what we all want.
Yeah.
But it's like we never can get to that.
Right. Yeah. And so it got me super excited. And I, to the point where I told my husband probably a year and a half, maybe even 2 years before it actually happened, I'm going to do this with somebody. I don't know who it's going to be. I know a lot of physicians. I know a lot of disgruntled physicians. I'm going to do this with somebody. And at one point in time, Dr. Moore, who is one of our physicians at Evolve, was in my office. We were working together. She had seen, I don't even remember how many patients that particular day. And I was just like, you look terrible. And she said, I feel terrible. And so I said, okay, what can I do to help? And she said, there's nothing you can do to help. I just had 5 people today 5 patients I saw today that I needed more time with, and I couldn't give it to them. We broke down her day that particular day. She had less than 7 minutes with each patient, which, as you and I discussed prior, that's actually above the national average.
Like nearly double, I think.
Yeah, exactly. And she felt terrible.
Mm-hmm.
And so I said, maybe we just need to have dinner. And so we did. We talked about this new model. And really, a lot of the studies even aren't on patient outcomes as much as they are on physician satisfaction and burnout. We know there's a shortage, especially in primary care, and a lot of that has to do with burnout.
Yeah.
And when they're seeing so many patients a day that they can only spend maybe 5 minutes, sometimes 2.5, 3 minutes with someone, and they don't have any kind of impact, that's not why they went into healthcare.
Would you say this is a doctor problem or a system problem?
I think it's a system problem.
Yeah.
Absolutely. Because I have not met a physician yet who is like, I love this. Yeah. I love seeing 100 patients.
Yeah, they come out bragging like, I got that one done in 3 minutes. Yeah.
No.
Nobody wants that.
Nobody wants that.
Mm-hmm.
And so I think it's a system problem, but that is the only way they can make it work because traditional insurance-based practices are really expensive to run because they're so resource intensive. And I'm not talking about resource intensive from a patient perspective. It's all the hoops that you have to jump through in order to get payment at all.
Yeah, which goes back to kind of the insurance thing of
right.
You have 2 weeks up to 2-3 months, maybe even a year before you get paid for a patient visit, and then
right.
We have to pay someone like you
right.
to go run all the coding for us to make sure we get paid. So there's another cost
right.
that it's like, well, I have to pay to get paid,
right?
And then you can just keep going up the chain. So everybody has to take $1 from this like patient's payment.
Right.
In order for the physician to actually get their $1.
Correct.
And again, not that we're in it for the money, but
No.
it's just like when you look at it as a business, which it is,
right.
there's a lot of costs that don't even go towards the relationship between the physician
right.
and the client or the physician and the patient.
That very first practice I was in, when I started, there were 3 coders that worked for me. And by the time I left 13 years later, I had 15 coders and we had 60 additional employees that were working in billing and collections.
Wow. I mean,
and that was a 75 physician practice or so.
And I mean, how many employees are at Evolve?
We have a total of 6.
Yeah, and I think we have 6 as well. So we have 2 full-fledged businesses that are less than half the size of what just the coding
right.
side of things was, where you were. And so that's another place where the money has to go. And like those jobs are needed 100%.
Absolutely.
But again, it's more and more dollars that are being taken away from just simply like, hey, I want to talk to this person who can help me with my health.
And we're not improving healthcare.
No,
we're not improving health outcomes. Sorry.
Yeah,
we're not improving health outcomes.
Down.
Correct.
Which is another like just overall frustration. And so you went and grabbed lunch or coffee with Dr.
So
Moore.
Anyway, so Dr. Moore and I went and had dinner. She's like, yes, please. Let's figure this out. And I told her, I said, well, Dr. Seacrest who was the physician I was referring to earlier with the hormone practice mm-hmm. and had already made kind of those shifts in his goals and aspirations for his career. And I said, he'd make a great partner because this is the vision that he has as well, even though it's not necessarily primary care. It's more hormone focused. They fit really nicely together.
Yeah, absolutely.
And just from what, I know hormones are kind of a hot topic and you'll get sometimes a lot of hate mail based on it because of all the controversy around hormones and their importance. But a lot of, there's a ton of research that really supports the fact that balanced hormones are the crux of all health.
To speak on that, what I've learned is, Ozempic and stuff like that is a hot topic. But when you actually get into the nuance, there's certain things. Hormones can be a hot topic where sometimes, everybody on social media just blames like, oh, your hormones are off. And it's like,
mm-hmm.
well, you could go get them checked and then have a conversation with the doctor and actually like get into the nitty gritty. And then you can go to, all surgery is bad. It's like, no, some surgery is 100% necessary.
Absolutely.
But it's often oversold.
Correct.
Injections, a lot of times are oversold, but sometimes they can be like game changing for people, right?
Mm-hmm.
And I think that's the ultimate thing here is social media has its way with like very controversial opinions. You have to pick one side or the other.
Mm-hmm.
And then when we go into like certain physician's office where you can tell it's just a money-making scheme, it's like, that's frustrating.
Sure.
But I think where care like what we provide and what you provide, where you actually have this thing called time to discuss with the patient. Now it's like, okay, here's some options that we could go to.
Right.
Is this something that you want? There could be these side effects. Do you know that? Here's where the benefits can come. Then we're going to take it one step at a time and we're going to go through this journey with you. And again, it goes back to what you and I think normal care should be.
Right.
But when you say like, hey, you may get some hate mail, it's like, well, that's because most of the time people want to have the conversation surface level.
Absolutely.
And not get into the nuanced details, which is what your practice and our practice provides, is time to go through
Right.
those things ultimately.
Yeah, I would say that I personally,
Mhm.
and I'm one of 6 people, actually 8 people that would be potentially answering the phone at our practice because the physicians are expected to as well if they don't have a live patient in front of them. But one of 6 people that primarily answer the phone, and I probably take no less than 2 or 3 phone calls a week where I talk to females especially that are crying because someone is finally wants to listen to their potential hormone complaints.
Yeah, I had one gal
and they
that
don't
was like
recognize
that.
them as hormone complaints, but it's symptoms.
Mm-hmm. What
And-
are, if you're okay, can we go down that route just a little bit? What are some of the symptoms?
Most of the time with the females that call in, most of the time it's brain fog, and they've been told that they need an antidepressant. It can be energy. Again, you need an antidepressant or an anti-anxiety pill is typically what they've been told to this point. They may be having hot flashes that are so out of control that it's affecting their daily life. And they, again, you need to, once you get, we might throw a few little remedies that maybe can help with it, but really it's just a rite of passage for women. And don't talk, and it's no fault of the physicians. It's just where your training lies. If you don't have specialized hormone training, if all your levels look in that normal range on the lab, but are you at the bottom of the normal range or are you at the top of the normal range?
Yeah.
And is the normal range really optimal?
For you.
For
in
you,
particular, right?
exactly.
That's what I've learned too, is like there's so much nuance. I know more about testosterone in regards to levels just because research and podcasts and
Sure.
stuff. But like, I think it ranges from like 200 or 300 at the bottom to like 1100 at the top.
Right.
Like you could
That's
have a guy
huge
that,
range.
I know, you could have a guy that's like, 1,000 in his 20s, 800 in his 30s, and then tanks to like 350 in his 40s. And the doc's like, no, you're all normal. It's like,
Mhm.
this is like a third of what I'm used to, potentially, right?
Yeah.
And then I know then you have estrogen, then you have progesterone in
Right.
women, which guys have both of those too, right? But in
Right.
different levels. And so you can be bouncing around, quote, within this normal range. And if we wanted to get into like the way they determine ranges is they just take a massive pool of people, right? And they're like,
Right.
all right, this is normal.
Yeah.
And so that's another
Another
whole
huge
nuanced
one
thing.
for females is just weight gain in the midsection. And oftentimes the once we like address it, the women are like, oh my gosh, I was just told I'm getting older and that's just the way it works.
Well, I thought it was just calories in, calories out, right?
Correct. Yeah. And so they're just so thankful. We had a female, actually, I'm working with her on weight loss as well, but she started out in our hormone practice. And I heard her filling out there's a symptom checklist that you would fill out when you came to our practice to start hormones. You'd fill out the symptom checklist right after you get your labs drawn. And then when we do your follow-up after we've initiated treatment of whatever that looked like for you, you do a follow-up and you fill out that same symptom checklist as they're drawing your labs. And she went to fill out her symptom checklist. And this is, I think, 6 weeks maybe after her treatment had been initiated from a hormone perspective. And I heard her tell the nurse who had drawn her blood, well, all of these are nothing now. Do I fill this out based on how I feel now or how I used to feel? She says, no, how you feel now. So in 6 weeks, just by dialing in her hormones, she was able to say, I don't have any of these symptoms anymore.
Yeah, which is life-changing.
Life-changing.
Especially because the one patient that I'm thinking of that had hormone issues, I think it was over 2 years. She was going to her primary care, like, no, something is off. This is not me.
Right.
This is somebody who stereotypically like appears ADHD, high energy. I think she was upper 30s, low 40s, somewhere in there. and you could just tell something was off if you knew her more than 6 months.
Sure.
And she knew it, but in her words, like I kept getting gaslit by my doctor that nothing was wrong.
Right.
And so I'm guessing that if
that's the typical, like I said, I get, no less than probably 4 phone calls a week that I encounter. That's the kind of thing that they've experienced.
This episode of Heal Without Harm is brought to you by Compelled Fitness, your ultimate partner in Wichita for getting into the best shape of your life. Whether you're aiming for better health, reaching athletic goals, or simply improving your fitness, Compelled Fitness offers programs and services tailored to fit your needs. Don't settle for less than your best. Visit compelled-fitness.com today and start your transformation with expert guidance and personalized fitness. At Compelled Fitness, the goal is helping you become the best version of yourself. Athletes and club teams, load up your gear with Van Gogh Transport Services. Led by local Ironman triathletes, Van Gogh safely ships your bikes, team equipment, or even bulky luggage to out-of-town events. Focus on performance, not logistics. Explore more at vangohtransport.biz. Yeah, which is so rewarding when you can have the conversations, have the evaluation, have the treatment that results in like life-changing stuff.
Right.
What blows my mind is we have our own version of that in our PT practice. And I'll look at my student who I've got now, Jake, and I'm like, dude, it's not rocket science. Just listen to him. Like, it's not hard. And I'm not saying like I'm smart, blah, blah, blah. It's just not hard. It's you have the time to be like, okay, here's what you've tried without success. Here's where the ranges are. I know they're quote within normal, or like I'll, test someone and say, I know their range of motion is normal, but there's some sort of dysfunction still going on here. Mm-hmm. Why is that there? And getting down to the root cause, right?
Absolutely.
And again, what everybody wants, but nobody's providing, at least what it seems.
Yeah.
Thankfully, it's growing.
Absolutely. I know it was probably within 2 or 3 weeks of Evolve opening, and Dr. Moore comes out of a room and she said, I kicked ass in there. And I turned around and I said, really? What did you do? And she goes, I had time. I just unpacked 3 years of frustration for this husband and wife, and we now have a plan for him.
Yeah.
The wife was crying. The husband was crying. She felt like she had kicked ass. Well, guess how much time she had with that patient? Because his wife and the husband both were new patients. Between the two of them, they had 2 hours together.
Wow.
And she used every minute of it. Mm-hmm. But by the time it was done, we had a plan, or she had a plan. The patients had a plan with her that they were so thankful. It was years in the making.
Well, especially because in my perception, in your 20s, you can do whatever you want. You live fine, it seems, right? In 30s, you're like, oh, wow. Me not working out multiple times a week is kind of starting to add up. Or me eating Doritos every night is kind of starting to add up. And then usually it seems by there, I'm sure there's studies on this, but usually somewhere in the 30s, people may be jumping on, 1 or 2 lifetime medications at that point. And then it kind of builds up again and then builds up again. So if I had to guess, just based off my experience and your statement of like 2 hours of talking, I'm sure this couple was probably upper 30s or higher.
Oh, yeah. No, I would guess they were probably in their late 50s, early 60s.
Okay. So you've got 2 or 3 decades of like small things that add up, small things that go unaddressed, small things that now compound. Like, okay, you're not sleeping at night because hormonal type stuff. Well, because you're not sleeping, now you're having more pain. And now that you're having more pain, you really can't sleep. Right. And now that you're not sleeping, now you're getting irritable and now you're fighting with each other and you're maybe going to lose the marriage. Like, it sounds dramatic, but over time, that stuff really happens.
Absolutely.
And so, yes, it's going to take 1 to 2 hours to unpack all of that.
Exactly.
And say, well, I tried this doctor, then I tried that doctor, we tried this treatment, I bought this supplement, which they promised me online that would solve all my problems. And we're like, please stop that. Right. Actually, on that, a study just came out that a lot of supplements are actually a harmful distraction. At least the ones that are generally sold direct to public, right? Because they have such high promise and low benefit that people will do those as opposed to just healthy lifestyle choices. So it's indirectly harmful and costly at that.
Right.
Just wanted to throw that blurb in there. Okay, so I really want to like finish out on like this last little gap. So you're having lunch with Dr. Seacrest and Dr. Moore individually together, whatever. How did you guys actually say like, you know what? We're putting a flag in the ground. We're starting to evolve healthcare.
Yeah. So from the time I met with both of them and they said, yes, let's go, to when we were open was probably about, I don't know, 5 months maybe.
Is that quick? That seems fast.
It's really quick.
Yeah.
It was really, when you're the person setting it all up, it was very, very fast.
Yeah.
But they were so on board by that point and they're just done with what they were doing, and myself as included. I was just ready to do something new that I felt like was going to actually make an impact. But also in the same sense, I wanted to make sure we did it right. And our goals, philosophies when we started was that we wanted to bring together like-minded physicians and patients in an environment in which they could take that patient to the level of wellness that they wanted to be. Because that's different for everybody. What everybody is willing to do or wants to do is very different. And so the way we could make sure that every service line that we offered outside of primary care, even primary care, when we were designing what that membership included, the lab that's included every single year for our members, it includes a deep dive into thyroid and hormone because our physicians truly believe that that is at the basis of true wellness.
It seems like when people keep having frustrations over 6 months, a year, multiple years, and they're like, hey, I finally figured out what was wrong. In my experience talking to patients, of course, in a PT world, it usually comes down to one of those two.
Yeah,
my thyroid, fill in the blank, or my hormones, fill in the blank.
Correct. And so we, like I said, the lab panel that's available to our members once a year as part of their membership, it includes that deep dive.
Does a normal CBC or metabolic panel get those?
No.
Okay, so
And
that's one big missing link of traditional stuff.
Hormone, quote unquote, hormone checks that are done even in traditional practice don't take the deep dive. Even from a thyroid, a lot of times they'll just look at the TSH. There's a whole lot more components to it than that. And same with testosterone.
Yeah.
You know, you have to know more than just the total testosterone.
Because there's like really total free and some other stuff too.
Right, exactly. And so our panels, even though they're not the least expensive or least costly to us to do, we feel like it is the right thing to do because then we know that we are living our mission, one, to make sure that we can look at every aspect to bring patients to the highest level of wellness we can. But again, it's the patient's choice.
Yeah. I think one thing that you're mentioning there is I've often said like bad physical therapy experiences do more harm to the PT world than like anything else. Like
Absolutely.
Everybody knows PT exists. They don't often know what all we can help with or when to go to a PT. But the second they go to a traditional like corporate owned physical therapy clinic and they get PT and they go through like 3 weeks of it and they're like, yeah, this is a waste of time, then they're never going to come see someone like me.
Correct.
Because they're like, I tried PT and they think it's all the same, which
Right.
I don't blame you. And then when they tell me what they got, I'm like, yeah, I would have quit too. I probably would have quit after the first visit. Like props to you for sticking with it.
Right.
But they have this, I tried that, it didn't work, checkbox.
Correct.
And they're not wrong for thinking that way. But what you just told me is some people would go get their blood labs done and they're like, oh, the thyroid, I saw thyroid in my blood lab. They said that was normal, so my thyroid's fine. Or they said they tested my hormones. It's fine. Well, we've already brought up a couple of patient cases, but that right there is, but did they go deep enough?
Correct.
Did they check the right things?
Correct.
Did they have the right conversations?
Correct.
To me, that again, like you said, this is what should be done.
Right.
But it's so frustrating because it's not what's done. And so another reason I wanted you to come on and talk about all this, because not everybody looks in depth or even knows to.
And I would say that's probably more what it is.
The knowing whether like to go deeper and
Is
stuff?
knowing to go deeper.
Mm-hmm.
And that's what, when someone comes in, they said, oh, I've been with my family practice doctor, if they come to us just for hormones.
Okay.
Because you don't have to be a member of our primary care in order to get access to our physicians for hormones or weight loss or a lot of our services. So they'll say, I've been talking to my primary care, keeps telling me I'm fine. Why didn't they ever tell me this? I actually did this. So when I joined the practice where I met Dr. Moore and Dr. Seacrest, I went to hormone training within 2 weeks of starting practice. Even though I was the administrator, I needed to know one of our largest, service lines. And so I went to training, and I had worked in the healthcare industry for many years by that point, and with all kinds of different specialties. And after first day of classes, I had dinner with Dr. Seacrest because he's on faculty for BioT. And so he was there at the training. I sat down to dinner with him and I said, I've been working with all different specialties for many, many years. And I've never heard, including OB-GYNs. And I said, I've never heard anyone talk about hormones like this. And he said, because that's not how we're trained. We are trained to be reactive. We are trained heavily in pharmaceuticals. when we're trained as physicians.
You're trained to be the ambulance at the bottom of the cliff.
Correct. We don't know.
Mm-hmm.
And so we don't ever look at it as the fault of the physician that they're coming from.
Agreed.
They just have a different background.
And they're so inundated with clients that they never have time to go look into the stuff themselves.
Exactly.
Yeah. Again, systemic or systematic problem.
Correct. Yeah. So it's not necessarily the fault of the physician, it's the system
Mm-hmm.
and the training. And so, seeking out someone who has that specialized training is really what you end up having to do.
Yeah,
and that goes back to advocating for yourself.
Yeah.
As a patient. I know you've had many of your podcasts have related to that. You have to be an advocate for yourself.
Well, and that's where,
unfortunately.
Yeah, Tammy, our second one, that's where I appreciated the statement that she made was, I went to my doctor and I was like, hey, I'm doing well, but I want to do well forever. And he's like, you're doing fine. Keep going.
Yeah.
And he's not wrong in what he said in regards of ill intention or anything.
Correct.
But like you said, he has no idea how to tell you to live longer. He knows how to fix you when you get there. And that's where I've told some people in our practice, there's this limbo between, I don't feel great, but I'm not bad enough to go to the sick care system. And then it's like, don't worry, just wait. Like in 5 or 10 years, you'll be bad enough. And that's where people are now, I think, seeing that they're about to walk off this cliff. They're like, those people just keep falling off and, getting hurt, falling off and dying. I don't really want to do that. But when they look around, no one else is doing it. So then they feel weird. They feel ostracized. Like, hold on, no, I want to stop this. What do I do? And unfortunately, a lot of doctors are not there to help them because they don't know or they can't. They don't have time. They don't have, whatever,
Correct.
The resources to help them. And so thankfully, more direct primary care places are popping up,
Absolutely.
Which, correct me if I'm wrong, if we just think like, hey, I'm going to my PCP or my doctor, it's generally a traditional insurance-based. The word direct primary care.
Or in some parts of the country, it's called concierge medicine.
Okay.
I like to use direct primary care because I think concierge medicine kind of gives you the impression that, you have to be rich to access it.
Yes, yeah, I agree with you.
And
there's a big connotation around that.
Yeah, so I like the term direct primary care, although I don't know if it tells the entire story. So I don't know what the right name is for it. But concierge medicine always gave me the impression before I started learning more about it and realizing it's the exact same thing.
Mm-hmm.
That you have to be rich to access it.
Yeah, which you don't at all. No, not at all. Especially, I'm sure if you went through a year of costs with a traditional doctor, if you're using them much at all, there's probably actually a huge cost savings along with lifestyle improvement.
Even for myself, and knowing everything that I know about the inner workings of insurance and healthcare and just the process, I myself, until probably, 6, 7, 8 years ago, realized that, oh my gosh, I can go to the highest deductible plan available. I can max out the savings that I'm using from the lower premiums. I can max out my HSA, which I get to keep forever unless I use it. I can max that out for my family, and I was still saving $118 a paycheck.
Which is either every 2 weeks or every month, which
it
really
adds
up fast.
Me.
Okay, yeah.
So I could be maxing out my HSA at $7,500 a year, whatever it was at the time, or is, and I was still saving $118 a paycheck.
Yeah, and that's money that's not going to the insurance company to raise their profits. That's money that you get to direct where it goes, and so this is where I think capitalism and healthcare can really actually go somewhere.
I agree.
Is put the money back into the client's pockets, let them direct where it goes. Because if you have to spend the money and it's not just insurance saying where to go, then you're going to say, well, I'm not going to go to John down the street. I'm going to go down to Evolve or, whatever that is for you in your location. And I'm going to spend it with someone who I know is going to help me get results.
Right.
And then the good doctors start to get bigger, and then they can bring on more good doctors.
Right.
And then those clinics grow because they're good at what they do and they actually get outcomes. And the clinics that are just in it for the money or they're not actually helping people, they start to go down. So now you have more resources being driven to good outcome providers.
There you go. I like that because initially you said good physicians or good doctors. And I think that it's not necessarily good or bad doctors.
I would agree.
It's, you're right.
Outcomes are not outcomes. Yeah.
Yeah.
And then again, Courtney actually just listened to a podcast that he was on. He's the owner here and who started Natural Wellness. He was talking about how the coaching system that he's a part of, who is trying to help physical therapists go from in-network providers to owning their own cash-based clinic. He's like, we get to save them from this like traditional model
Yeah.
and pull them out and say, hey, go flourish like you want to do. And that's essentially what you, Dr. Seacrest and Dr. Moore did, right? Like you were like, hey guys, this is bad. Let's jump ship and go like create this new, better thing. And we can only do that if we do a good job getting outcomes, asking our clients and patients for referrals, and then having more people like consume our style of care so that they can get better outcomes themselves and help their friends and family members also get those good outcomes. I'm curious, do you know the difference? Because I'm starting to learn a little bit more about this, but I don't know a ton. Do you know the difference, whether it be primary care or like physical therapy or some other medical business? What's the difference between like physician owned and corporate owned? Do you know much about that world and like those two things?
Because I've worked in both.
Okay.
So physician owned means exactly just that.
The doctors there own it.
By the doctors that are there, most likely. The very first practice I was in, where I was talking about the surgeon and the $400,000 worth of claims, that was a physician owned. Still is. It's probably one of the larger ones in Kansas.
Okay.
But they are physician owned. And then beyond that, most of the large practices, so when you start talking about corporate owned or even hospital owned to a degree, so you'll see like the family medicine practices that are associated with a hospital. So they're hospital owned, which is more of a corporate type structure, where physicians aren't necessarily the ones making the protocols and policies and, things like that. It's coming from above.
Yeah, which is generally business style people and like very what you would think of as corporate. So incentives are starting to switch.
Yes.
A little bit.
And so even the hospital that I was at in Austin was a corporate owned, meaning our corporate office was in Louisiana. We had hospitals all across the country. But my corporate counterpart was in Louisiana. And so it was very much driven from like what was happening in our hospital was being driven from Louisiana.
Would you say more times than not? I know this is a general ask and I understand you have to provide a general answer, but would you say more times than not physician-owned clinics are going to develop better outcomes as opposed to a corporate, or is it almost kind of a wash?
I think that I think it depends on the style of practice, because I think even if it's physician owned and it's insurance based, the insurance companies are directing the outcomes.
Yeah, that makes sense. You can still follow the money in a way, back to insurance being a dictator of.
Yeah, I mean they don't really have a choice.
True.
I mean,
You're 100%
right. They have to
right.
either do what the insurance company deems as medically necessary or appropriate care. They have to do that, or they don't get paid.
Yeah,
you don't get paid, you shut down.
And they legally can't pass that on to the client.
Correct. If they're contracted. If they're contracted with that insurance company, they only get paid if the insurance company says they get paid.
Yeah.
And you can only bill the patient if it's a patient dictated responsibility from the insurance company, meaning deductible co-insurance, that type of thing.
And so I've actually heard outside of just physical therapy, more and more, we'll just say medical providers as a whole, even ones that are insurance-based won't accept certain insurances because they know they won't get reimbursed at all or reimbursed enough to even keep the lights on.
Correct.
And so if you're a consumer of the healthcare system right now and you're getting frustrated because your insurance isn't getting accepted places, it's not because they don't like you or they don't like that. It's like they will not get paid and they cannot serve you overall. And so the more that you can kind of potentially, like Kellie said, grab your cost savings by paying a smaller premium, having a higher deductible, and then reallocating or dedicating those dollars to where you can spend them, where you want to spend them at a place that's going to serve you. That's ultimately the shift that I think will help most people.
Right.
Let's move on a little bit to who all do you serve at Evolve Healthcare? Because you've mentioned primary care, you've mentioned a little bit of hormonal type stuff. What are all the different clients that you treat there, or what do you guys have specialties in maybe?
So we, from a primary care standpoint, we accept anyone, just like
a normal
even traditional primary care. I don't like it necessarily the term, but they say from birth to grave.
Okay.
So we don't like have any age caps or anything like that. And even with our primary care memberships, we don't have a fee schedule or a membership level that is dictated by your age either.
Oh, really? So
other than children are less than adults. So 18 and under as a member with their parent or guardian. have a lower rate. But from an adult perspective, we don't raise the rate the older you get.
Okay.
We did that strategically because we felt like if we were doing our job well, it wouldn't matter whether the patient was 90 or they were 20.
That's a really good point because we know that the older generation is going to consume more healthcare because if we talk about compounding.
Correct.
Health,
traditionally.
Yes,
They
traditionally,
would be resource intensive is kind of how we term it.
I like that because then you're incentivized even more like, hey, we're not going to make more money. If we just go business, right?
Yeah.
You're not going to make more money off the 55-year-old because you've elected to have a pay schedule that they pay the same amount.
Correct.
So then you're further incentivized to keep that person healthy from a financial perspective.
Correct.
Outside of just the goodness of your heart, to keep them consuming less of the medical type thing. I like that. I like that a lot.
And I mean, I think, I don't know if it was one of the physicians I was working with or one of my friends who is a physician who knew what I was trying to do. I don't remember which one it was, but they said, that's crazy. How are you going to make any money? And I said, if we do it right, we will be just fine because our patients will be healthy.
Exactly. It's scary to start that, but yes.
And we've seen that. So, both physicians came from a traditional insurance-based practice where they both had a decent amount. Well, Dr. Moore had a huge primary care practice. Dr. Sechrist, as I said, had been already kind of moving towards more hormone. But so the majority of our patients or our members initially were from the traditional insurance-based model, and some of them were really sick. And they were heavy consumers of ER visits. They were heavy consumers of utilizing, the system, if you will. And now there was one of the patients that we used to see almost weekly when we first started. And I remember asking someone last week, hey, I haven't seen so-and-so in a while. How are they doing? Oh, yeah, they're doing great. We've got them off of this med and this med and this med. And yeah, we only see them about every 3 or 4 months.
That's awesome.
And that was somebody who was in the ER often.
Again, somebody who you could probably charge a higher dollar amount because they consumed more healthcare.
Absolutely.
That you both share the incentives.
And we're in a higher age group.
Yeah.
Because you will see that sometimes in this model is that, depending on your age, you have a different membership level. And we just felt like if we did our job well, that we wouldn't need to do that.
Yeah. So, direct or normal primary care. No, you're good. You're good. Direct primary care. What else do you guys?
So we do direct primary care, and then probably the next, actually, which is even bigger than primary care, is our hormone practice.
Okay.
So we, Dr. Sechrist he's almost 100%. I think he might have 10, 15, 20 primary care patients, but at this point, the majority of what he's doing is hormones. And that's where his passion lies. He loves hormone. He also teaches as on a faculty and a national mentor for BioT hormone. So that's his world, that's his passion. And that's really what we wanted to try and also build with Evolve is I want the physicians working there to be able to follow their passion.
Yeah, like truly flourish in it.
Yeah, exactly. Because they're not, not everybody's interested in everything, and they can't be if they want to be really good at it. And so that's his thing. That's his passion, and that's what he does probably 99% of the time. And then Dr. Moore has a little bit more primary care. She also does some aesthetics. And female health wellness is really her passion. So she's taken on, as she's gotten into hormones and things like that, she's been getting more and more referrals for even PCOS and things like that. And then she also on her female health platform, she's able to address like urinary incontinence, non-surgical approaches to urinary incontinence and different sexual dysfunctions with females and things like that. And so that's really her passion is female health. And so she has a pretty decent following for that. We also started weight loss 2 years ago, I guess now, really and when I say weight loss, we started the GLPs, the Ozempic, Mounjaro, or the compounded versions. Did it because everyone was asking for it, but did not want to be a weight loss clinic.
You guys were hesitant at first.
We were very hesitant. Probably me more so than the physicians, but wanted to make sure that if we're adding a service line, that it still is aligned with our goals and missions of making sure we're helping people get to their best self or to their highest level of wellness. And the GLPs at that time, I didn't know that much about them. And so I'm like, the publicity at that time was, people are going to lose weight, yes, but then they're going to, look like a walking skeleton. They're going to be skinny, fat, all these things.
Yeah, you got Ozempic face, Ozempic butt,
exactly,
all the negative stuff.
Exactly. And so we've really developed our program really to be more focused on, yes, weight loss, but really body composition change so that we can help people age well. And even our lab that we require for all of our weight loss patients, whether they're one of our patients already or not, if there's somebody coming from the outside just for weight loss, they get the same lab panel as our hormone patients, as our primary care patients, because what we know with even weight loss and weight management is hormones are at the crux. So we do a deep dive into hormones and THA or thyroid, and then we kind of go from there.
Did you mention when we talked before that you also do a body scan of some sort?
We do.
Am I correct on that?
Yep. So every patient is required to do a body scan and routine body scans so that we can see what their body composition is. We're most focused on not so much the scale as bringing down the fat and bringing at least maintaining the muscle they have, because when they're on the GLPs, depending on what dosage and things like that, sometimes it's hard to build. I've had patients that have built muscle. Actually had one just yesterday who is getting back onto the GLPs because she has gained a little bit of weight, but when we looked at her body scan, she actually has gained a little bit of muscle. So, and not gained complete fat.
Yeah.
So anyway, so yes, we do body scans, and that's a requirement of our practice.
What all are you getting from that body scan? Like what information does it tell you about the patient?
So the majority of what we look at, it's going to give you lots of parameters, but the majority of what we're looking at is their skeletal muscle mass, lean mass, their body fat percentage. That's the majority of what we take from it, because that affects how we dose the GLPs. And how we gauge success with them.
I think I may be off on the numbers a little bit, but traditionally when someone loses weight, let's say they go from 300 pounds to 200 pounds, just for example, I'm pretty sure the last thing that I saw that if you do it with just diet and exercise alone, the more old school traditional method, right, you'll usually lose about 10 to 20% of the weight that you lost will be muscle mass. Because we know in general, like it's got to come from somewhere. Most of it's going to be fat, but generally, traditionally, some of it's still going to be muscle. Also, when you're walking around 100 pounds lighter, you require less muscle to do that. But some of the studies that I've seen with Ozempic or some of the GLPs, people can lose upwards of 66% of the weight they lost is muscle. So they really are completely malnourished through the process. And really I think that's what you're trying to fight.
Yes.
Is that
and
correct?
Really that doesn't come from the peptide.
Okay. What is it?
So the GLP, that's not what's causing it. What's causing it is we are dosing it so hot, not us, but in general, it's being dosed so high that we're killing the appetite. People aren't able to take in appropriate nutrients. And so, yes, the scale's going down, but your body's eating up the muscle because you have nothing to feed it.
The fuel has to come from somewhere.
Absolutely. It has to come from, the energy has to come from somewhere, right? And also, we're not doing any kind of resistance training. And even I was guilty 2 years ago, 3 years ago of cardio is best, right? I was a runner. That's how I met your
Courtney.
your Courtney Morrissey.
Yeah.
But I was a runner. And I would think, okay, well, I ran 12 miles today, so, I can eat 1,200 calories.
Yeah.
Well, that was completely wrong.
I'm pretty sure you'll burn more than 1,200 calories on that 12-mile run.
Exactly. So in my feeble, uneducated mind, I'm like, okay, well, I'm good. I'm going to lose some weight, right? And I kept inflaming my body, body fat percentage kept going up, muscle mass kept going down. Scale may or may not stay the same depending. And a good friend of mine who's a strength trainer, Anna Woods from She Strength, I met with her and I was like, I don't know what's happening to me. And she goes, I know what's happening to you. You're running too much. Your body has no idea when you're going to feed it again. And so it's storing everything it has as fat. Anything you give it, it's going into fat because that's what the body wants. And then it's going to hold on to it, Kellie. It's not going to release it.
It doesn't
because it doesn't know when you're going to give it anything again.
Yeah, it's straight survival.
Yeah, exactly. And she goes like, stop it. And so it took a long time. It took a huge mindset change. But finally started prioritizing protein, started finally prioritizing calories if I was going to run, and prioritizing strength training.
For sure.
Which I hate. I still don't like it.
But it's a necessary thing, right?
Absolutely.
Like the muscles Muscles are an inefficient organ to hold on to. They require calories and they require work, ultimately.
Yep.
And I think as people get older, they're ignorant to the fact that they have to put in work to keep their body moving like they want.
Right.
We would rather pay for or have somebody do something to us or for us or give us as opposed to just simply strength training.
Right.
And it doesn't need to be super complicated, but it does take initiative and you have to take responsibility of it as you get older. And that's where I'm trying to wrap my head around on how to deliver that message to more people.
And that's the conversation. That's the very first conversation. I'm doing the majority of our weight loss visits now.
Okay.
They meet with the physician, figure out what the best plan of care for them is, which GLP, if there's a GLP that needs to be involved, or is it just nutrition and, whatever. And then I do those initial visits with the patient. And that's one of my first question is, what's your goal? And almost always it's a number on the scale. So then the second question is okay, why that number?
Mm-hmm.
And the why behind that number is really what's most important. And almost always what I'll hear is that's when I felt my best. So then the follow-up question to that is, okay, how many years ago was that?
Yeah.
What age were you?
And also, so then to me, the question of the question, which is something that Kayleen and I kind of talked about, is so you don't really care about the number, you care about the feeling you had associated with that number.
Correct.
Right?
Yeah, because that's really why that number exists.
Mm-hmm.
I had it with my own
journey.
It's
either a perspective or the things you associate with it.
Right.
Which is not, I'm not going to say that anything is wrong about that, but
no.
I remember I had a patient who she was, we'll just say very slender, consuming a lot of protein bars every single day because she knew to prioritize that. But I'm like, okay, but everything you are eating is like insanely processed.
Right.
And so as I asked her to start eating more whole food, she's like, Clayton, the scale's going up. I've gained 8 pounds since we've talked. And I'm like, yeah, and you look great.
Right.
But ultimately, I remember I had the question that I boiled down to, which you may have your own variation of. And if anything, you may be able to use the question. I said, if you looked and felt exactly how you wanted, would you care about the scale? And for her, she still did, because a lot of women do. And I don't blame you in any capacity. There's a whole society that tells you things. But it's like the number matters less if you look and feel how you want. Because what I heard is that she wanted to look a certain way and feel a certain way, but she heavily associated the number on the scale with that.
Yeah.
And I'm not saying it's easy to dissociate.
It is not easy, and especially with women, because we have been trained to go just by the scale.
Yeah, for sure.
And I think the first time we met, I told you I had been everything from obese to anorexic and everything in between. And at 50, I'm finally feel my best. And my number on the scale is about probably 9 to 10 pounds heavier today than it would have been if you asked me what my goal was 3 years ago.
Yeah, so a big shift of expectations in a way.
Right. But it took a lot of work to get my mind to change. And like Anna, when I said, she says, I know exactly why this is going awry. And when I changed what I did and changed the mindset of, okay, instead of everything that I put in my mouth, I have to go burn that number of calories, then everything that I put in my mouth has a job to do.
Yeah, to fuel you. It
has a job to do. And if it can't meet the job that I know it needs to do, then I don't put it in my mouth. That was the mind shift for me.
It's a big litmus test of, do I need this? Does it serve me? Does it help me reach my goals?
But that's different for everyone.
It is.
And that's what we try to unpack with. So our program is a little different. It's a little more intensive in the sense that they have to come see us, i.e. they have to come see me like weekly for quite a while. And I actually have some patients that could be quote unquote at home, meaning that they could have graduated out of the in-office and seen us all the time and only see us every 4 to 6 weeks. But they continue to come because they know they haven't gotten over the hurdle of whatever that mindset was. And so, but getting people to shift, think, okay, protein is my friend and resistance training is non-negotiable, is hard, especially in women.
Yeah.
And that's why we are working to try and create partnerships for the strength side, the exercise side, because that's not our expertise. And so we're creating partners in the community. So like Compelled and She Strength and just people that we know, those trainers, those coaches, those owners have the same philosophy we do. And that they know that we're using the GLP as a tool to get habits shift. To change.
Yeah, yeah.
It's really just a tool to let habits change. Can you be on those GLPs forever? Absolutely, you can. But should you? Probably not.
Mhm.
I don't know. I'm not a doctor.
Yeah.
But we use it and we view it as a tool to
Mhm.
get habits to change.
Yeah, which I have friends that have taken, and that's where they were like, Clayton, I know you're not gonna like this, but and it's like, no. If that helps you change your life, which they have,
Absolutely.
then go for it. Like, and plus, like, you do you, girl. Like,
Mhm.
that's like on you, like completely you.
Yeah.
But again, like the more reliant we become on certain things, or like lifetime medications, especially when I don't know if there's research around taking out these dosages for years and decades.
There aren't.
We know there's going to be consequences, and it's like, are you willing to pay that price? Because that's the price you don't know you're paying now,
Right.
but you'll figure out later. Like,
Right.
is it just a detour that you're going to end up at the ambulance at the bottom of the cliff? Is it just another route to get there?
Right.
Overall. And so we're going a little bit long today, but
Sorry.
no, you're good. I think all of this is valuable, and if anything, we may have you back to like digress on some other things. I do want to ask you though, if you had to boil down today's conversation to like just one piece of information that you want a listener to take with them today, what's like one of the most important messages that you really want the average person to know, whether it be medical system, treatments, anything in that world?
I think everyone has to advocate for themselves. You have to decide, is this provider like-minded with me? Do they share my goals? Do they share for me?
Mm-hmm.
Not necessarily for the masses, but for me, because everybody's different. And what my perception of me aging well and what the next person's perception of aging well could be completely different, and their goals are going to be different. Not every provider is a good fit for every person. I think I shared with you initially, I met Courtney because I had 7 other physicians or people that told me just to stop doing what I was doing.
How many again? Sorry.
I think there were 7.
7. Okay,
Yeah.
gotcha. That's a
and
lot.
Most of them doctors.
Yeah, and most of those people
physicians.
Most people will stop at 1.
Correct.
Most people you have to pull teeth to get them to go see a second opinion. So the fact that you had 7 different ones and then finally found someone that listened.
Finally, Dr. Seacrest, I was talking, just shooting the crap in the hallway with him, and I'm like, I'm really frustrated with this. He goes, go see Courtney.
Yeah.
And he was finally the one that said, no problem.
So keep searching, everybody.
Keep searching and find the person that works for you.
Mm-hmm.
Find the practitioner that works for you.
Yeah, and if you see a friend or a family member or even just someone on socials that started similar to where you feel now, and then you see them get results, reach out to them and ask them, who helped you? How'd you get there? What'd you do? Because sometimes it's not even like, oh, I'm going to go to the next doctor on the list. It's, I'm going to talk to someone who will help direct me to someone else, who will help me direct to someone else, and then finally get to a doctor, physician, PT,
I would
whatever.
say the majority, I know because I watch statistics of our business, but the majority of our referrals, I would say probably upwards of 95% or better are personal referrals. Not marketing, not outside marketing.
Yeah, because people want this. They may not be in a position where they need this yet, but when they see someone else go from like bad to great, ultimately they want to know how to. And so I think that's a big piece of it.
Yeah.
A couple random questions and then one in-depth one, and then we'll finish up. What is a favorite food or snack that you could eat nonstop?
Okay, I really wanted to say something healthy, but it's chips and salsa.
Yes. Okay. Particular chip, particular salsa, or a certain restaurant?
Yes. So I live in Hutchinson.
Okay.
And so I would say chips and salsa that I could eat all day, every day would come from a place called Cancun.
Okay, gotcha. I was going to guess the Anchor. Do you eat there much? Do you like it? What is it?
You know what's really interesting is the Anchor is a nostalgic place for Hutchonians.
Yes. Oh, no, I only remember that because when we had baseball tournaments there, we'd eat there. And then I remember I went back and I'm like, it's okay.
I mean, I like the Anchor, and I will tell you what, the Flores family are amazing. They are absolutely amazing. They're the ones that own it.
Okay.
And have for, I think, since its inception. I'm not 100% sure. But no, it's good. But when it comes to chips and salsa, I'd say Cancun's my choice.
Gotcha. What's your why behind all this? You and I both share a deep passion for what we do, but why? Like, why do you care so much? Why are you so passionate?
I think the reason I care and I'm so passionate is because I want to provide an environment that not only, like I said before, the physicians can flourish and see their passions fulfilled, but then it can then translate to phenomenal outcomes for patients. And that those decisions are being made between the two of them.
Yeah, because that's what really matters.
Not an outside entity.
Mm-hmm.
Yeah, I would say that's probably my why. One of the other questions you had sent me at one point was when did that passion start, or something to that effect? And I thought back, and really it's been since I started my career.
Yeah.
because I naturally gravitate towards individuals. Most of my career has been in healthcare, so physicians who are disruptors and visionaries, and they were ahead of their time, if you will.
And it takes you a while to find. I feel like it's two things. It takes you a while to find those people, but it also takes enough like bad evidence or like frustration to like create an action threshold that you're actually willing to go build or create.
Yeah.
If that makes any sense.
Yeah.
Like it's years of frustration. It's years of like problems. Like, you know what? I'm going to stop like working for someone else. I'm going to stop trying to change the system, and I'm just going to go build new.
Right.
Like that's the only way.
Well, I told you initially, I'm like, I'm getting out of healthcare.
Yeah. You're like, just throw your hands in the air. I'm out. Like I can't do this. Yeah. No, I'm with you there.
Luckily, whether it was, God, I think, was the one that shifted things, and it's like, no, he's the one that put that door shut. No, you can't leave healthcare. And I think it's because it led me to what we have now.
Yeah, for sure. Which, if we want to go, one layer deeper, it's like, how many people wouldn't be helped if you didn't do what you did, or if God didn't shut that door and help you meet Seacrest and more and all those things? Because now you guys are helping a high number of people in the Wichita area, potentially going to grow bigger than that. And it's like another proof of concept that this is a good style of healthcare that actually gets outcomes, so on and so forth. And so it's always fun looking back years later and being like, oh, that's why that prayer wasn't answered.
Right.
That's why, that bad thing had to happen. And then you start to see all the dots and you're like, you got me, dude.
Exactly.
Like,
Exactly.
You get me. So to wrap things up, if someone's listening right now and they are, they're in their car and they're like, hallelujah, I found somebody that can actually help me. Where do they go after this podcast to try to see you guys over at Evolve and try to get in contact with you? What's the best way?
So I would say go to our website and there's a form on there that you can contact us, or our direct phone number, and I guarantee someone will answer the phone. We have a rule in our office that if the phone's ring twice and you don't have a live person in front of you, you better be answering it, including
I like it.
Physicians. So you will not get an answering machine or a triage. But when you go to our website or you Google us, you need to make sure you're looking for Evolve Healthcare, because there is an Evolve Health and Wellness in town.
Okay.
Who is fairly close to us, but we are on Ridge Road, and it's Evolve Healthcare. So website is evolvehealthcareks.com.
Perfect. And I'll make sure that's down in the show notes. So if you guys just want to click a link instead of trying to Google some things, you can click there, go to their website and check them out. I want to say thank you for listening today. If you haven't already, please make sure you're subscribed. Last time I checked numbers, it seems about half the listeners are not subscribed, and I don't want you to miss any of our episodes. And then we've actually already hit double digits on ratings and reviews. So if you can please share with a friend, if you could please go leave a review if you haven't already. Words mean a lot to me. I love to read them, but even just hitting 5 stars is extremely helpful. Helps us bring on better guests, more guests, and reach more people and kind of save them from traditional healthcare ultimately. Kellie, before you go, is there anything else that you would just like to leave as a piece of advice or any other notes that you'd like to leave for the listeners?
I don't think so. I really appreciate you giving me the opportunity to come on. I think I shared with you when I first said, hey, I want to know you. It was after listening to your podcast with Alan. And I'm like, yes, these are my people. Yeah,
absolutely. I remember your email. You were like in your car, like, yeah, like screaming by yourself.
Exactly.
For sure.
So I just really appreciate you. And then probably a last piece of advice, again, just everyone advocate for yourself.
Absolutely. So I want to give more platform to more voices like Kellie's. And so, like I said, please share with a friend. I'm sure there is someone in your life right now that could benefit from the care that they provide at Evolve Healthcare. So please do your duty as a good friend and share that with them. And if anything, I hope you learned a little bit more today about how to heal without harm. Thank you, Kellie.